If you are someone who struggles with endodontic management of open apices, then this video is for you. Today, we are going to take a deep dive into complete clinical management of open apices. If you get an endodontic case with an open apex in your clinic, by the end of this video, you will know exactly what to do and how to manage the case. My name is Siju Jacob. I've been in private practice for the past 25 years in Bangalore and Dubai. I've also been using a surgical microscope in my own private practice for the past 20 years. In addition to private practice, I've also been teaching dentists how to work with a surgical microscope. And this is something that I've been doing for the past decade. Today, we're going to take a deep dive into endodontic management of open apices. Cases with open apices cannot be managed in the routine endodontic way. And the reason why they cannot be managed is when you have an open apex like this, whatever obturation material you put into the tooth will not have any retention. It will go past the apex, number one. And two is it will not be able to seal the apex because the apex is too wide for gutta-percha or sealer. So this is the reason why they are challenging. That's one part, that is the apical part. The other part, of course, is the cervical part as well. So if you look at the tooth with an open apex, there are two problems. One is, of course, the open apex, which makes it difficult to obturate. The second part is the weakened pericervical dentine. So if this tooth becomes non-vital very early, or if you start full-on endodontic therapy in the beginning, like how you do a regular endo, then this weak pericervical dentine will result in fracture of the tooth. So these are the two main challenges when a clinician deals with open apex cases. So let's take a look at how to manage these sort of cases. And this problem with weak cervical part or the open apices is not just restricted to anterior teeth. They are something that can happen even with posterior teeth. So you see this is a mandibular second molar, and you can see the apex is wide open. In addition to that, the cervical part also is quite thin. When clinicians try to manage open apice cases in the regular way, and they start doing or obturating these cases the way they do every other case, then in the short term, sometimes nothing much happens. But in the long term, this is what happens. Because of the fact that the clinician cannot seal the apical area, lesion starts developing, and then usually the patient shows up with either a swelling or a sinus tract. And then when you take a radiograph many years down the road, this is what you see. You see a big lesion, and then you see a canal which is obturated, but the apex is wide open. Some of these cases also end up this way because they've already been through a round of surgery or even 2 rounds of surgery. So this is usually the clinical presentation. The second problem, of course, is if the cervical area is very weak when you do endodontic therapy in very young teeth, then usually this part can fracture. So that's the second problem. So the way I look at it, rather than getting into too much of theory, the way I like to do this is try and categorize these into clinical scenarios. Like if you and I get a case like this in our clinics, how are we going to manage this? How are we going to differentiate all these different clinical scenarios, and how do we plan treatment? This is what I want to talk about in this deep dive about open apices. Now, if you ask me, these are the following scenarios that one usually sees. So we're not talking about a young patient where there is an intentional exposure of the pulp. The patient's asymptomatic and the clinician is just doing some sort of a cavity preparation. And while doing cavity preparation, there is a pulpal exposure. I think we all know how to manage that. We're talking about direct pulp capping and stuff like that. We are talking about those endodontic cases where patient comes to the clinic with acute pain, and when you take a radiograph, we find an open apex. So how do you manage these sort of cases? You can't just do direct pulp capping in these cases. So we are talking about those kind of cases, okay? So the first scenario is something like this. So you have a scenario where there is deep caries, tooth is symptomatic, okay? Patient has quite a lot of discomfort, which means irreversible pulpitis, which means pain lingers when stimulus is removed, and there is pulpal exposure. The pulp is exposed, and the patient has reported to the clinic with irreversible pulpitis. Okay, this is one scenario. The next scenario is where, again, the patient reports to the clinic, and when you do a pulp test, you find the pulp is completely non-vital, which means it's necrosed, and tooth is non-vital. The apex is large, and there is not a lot of periapical changes. Okay, so the lesion is, you can kind of see a lesion, but it's not that big a lesion. So this is the second scenario. The third is the tooth is non-vital. There's a large periapical lesion associated with the open apex. So the lesion is pretty large. So according to me, this is a slightly different scenario and should be managed accordingly. So these are the various clinical scenarios that one encounters in everyday clinical practice. And we are going to take a deep dive and sort of have some framework as to how to proceed depending on these various clinical scenarios. So if you ask me, I like to categorize treatment options in the following way. So this kind of gives me an idea of how to proceed. So let's say a tooth has a pulpal involvement and there's an open apex. The first thing we see is whether it's vital or non-vital. Now, if the tooth is vital, then the first thing we see is it symptomatic or asymptomatic, right? So if it is asymptomatic, then yeah, pulp capping is an option. If it is symptomatic, then our goal is to do apexogenesis, which means we have to sort of remove a part of the pulp and then allow the uninflamed part of the pulp to continue growing. That's what we call apexogenesis. And then once we know that the tooth isn't vital, which means the tooth become completely non-vital, then obviously there is no apexogenesis. Then the options that we have in front of us are revascularization, apexification, bioceramic barrier at the apex, and finally, if none of these work, then yes, surgery is the last option. Okay, so these are the modalities that we have at our disposal, and we are going to look at each of these in detail. Let's start with apexogenesis first. Now, what is apexogenesis? Apexogenesis means the patient is reported with irreversible pulpitis and the coronal part of the pulp is inflamed. So if you see the pulp coronally, it bleeds a lot. Okay, so it's very, very inflamed. And if you do complete pulp extirpation, then the apex is not narrow enough to do conventional endodontic therapy. So what are our options in this case? So we always attempt, if a part of the pulp is vital, then we try and do a bit of pulpectomy, something like a coronal pulpectomy, which means we selectively remove that part of the pulp which is very inflamed and then leave the pulp which is not that badly inflamed, hoping that it will recover. And that pulp which remains in the canal will continue development of the root. When you say development of the root, it means the root will form, or the root closure will happen in the natural way. And the cervical part also will get thickened. So this is the goal. So let's look at this particular case where the patient turned up with acute pain. And our goal here is to do apexogenesis by removing the pulp till here, leaving the apical part of the pulp, the radicular part of the pulp, and then sealing the coronal part, and hopefully the apical part will continue to grow. This is the goal. So this is how a clinical scenario is. And you see very soft decay. We start cleaning it up, and the minute we start cleaning it up, there's lots of soft decay inside, so you can't leave it like that. The patient is in pain. And the minute we clean up the soft decay, you can see extremely inflamed pulp. So what we did in this particular case, this is a young boy, I think he's 11 or 12 years old, and we clean this up, the coronal part, and then we get to the stage where the inflamed pulp is removed from the chamber, but the radicular pulp is not that inflamed. So that's the radicular pulp. You can see here, you can see pulp which is quite vascular, but not inflamed badly. By the way, these pictures are all taken through microscopes. So in case you're wondering, this kind of documentation is something that every one of you can do in your own clinic. If you don't know how, then do have a look at my online course. We go through everything. We teach you how to start with the microscope in your general dentistry practice, how to attach a camera, and how to take pictures like this. It's something that everybody can do. Do have a look, and hopefully many of you get motivated by seeing these sort of pictures and eventually move on to buying a microscope and putting it in your own general dentistry practice. So what we do in this particular case is we cover the radicular pulp with a layer of MTA, which is what we did, put some gray MTA there, and then I put a cotton pellet over that and close it with glass ionomer cement. The idea was to leave it alone and then recall the patient after a week or 10 days, check the hardness of the MTA, and then put some composite resin over that. But then this is how the patient left the clinic. You can see here, that's the MTA, and then there's a cotton pellet over that, and then there's glass ionomer over that, which was meant to be like a temporary filling. So this patient came back for a recall after 1 year, and this is what we found. We found that a part of the glass ionomer restoration was chipping away. So we decided to bring him back. But if you look here, you can see that the root development is proceeding. You can see it's become much more narrower than what it used to be. And we also found that cervically, there's more deposition of dentine. So the cervical strength is much better than what it used to be 1 year ago. So we told him to come back and we would just replace the temporary filling. But this patient missed his appointment and then showed up after 3 years. And you can see the temporary restoration is still in place. And you can see a lot of the temporary restoration is broken, but a large part of it is still in place. And you can see the root is actually formed pretty good. The apex is kind of closed. Cervically, there's a lot of deposition. So what we did when this patient came back after 3 years is this is how it looked. You can see it's completely dark, and this darkness is actually not decay, it's actually MTA. And sometimes it can happen if MTA is left for long periods in the tooth, then the tooth can get discolored, especially gray MTA, but even white MTA can discolor. So that's what happened with this particular patient. You can see a lot of discoloration. And when we removed it, you can see that's the cotton which I placed 3 years ago. Once you take it out, completely black, and the tooth surface is completely pitch black. So when you start cleaning this up to see what's inside, this is what we saw. And it's pretty amazing how the pulp that you saw in the previous picture, how it stimulates reparative dentine formation here. So you can see here, this is what happens. So mesially, the reason why the patient came is because he had some discomfort. And the reason he had some discomfort is you can see reparative dentine here, but there's a small exposure there. So this is how it looked mesially. So this part had become inflamed and it started hurting him, and that's the reason he landed up in the clinic. But when we look at the distal surface, you can see a nice thick layer of reparative dentine there, which is completely uniform, and there is no leakage at all. So there's very little reason for us to go back in there. So what I did in this case was I just cleaned up the inflamed mesial portion. I did an endodontic therapy because at this point in time, because it's 3 years since he came to us, and the root has actually narrowed down. So it's actually conducive enough to do a routine endodontic therapy. But however, I left the distal part as it is. Because I didn't see any reason to do anything there, because you have a nice thick layer of reparative dentine and the underlying pulp inside that I presume is healthy enough. So why go there in the first place? So what I did was I clean shape and obturated the mesial half and then restored it with glass ionomer, instructing the patient to come back and then plan for something definitive. Because this patient, the restorative prognosis is not great for this patient, even at this stage, but he's still a young boy. So we thought this is a much better alternative. And you can see here, if you compare the post-op that is here from what it was 3 years ago, you can see the continued root development apically, both in the mesial and the distal root. And you can see thickening cervically as well. So we believe that this is a classic apexogenesis where you allow the root formation to happen naturally by preserving whatever vital pulp is there in the radicular portion. So this is an example of apexogenesis. Yes, it looks a bit odd, a bit different from conventional endodontics, but I think this is a good result. I lost track of this patient because he moved down, and hopefully he has managed to keep this tooth till the time he's an adult, so in his 20s or something, where he has more options as to what to do. So the goal in most of these cases is to prolong the life of the tooth as much as possible in these young patients so that it reaches a stage where it can last well into their adult life so that they have more options at their disposal. So that's the goal many of the times in these sort of cases, because they come to us in such bad shape restoratively that you're not hoping that it will stay whole life, but even if we can at least get 10, 15, 20 years of life on these teeth, then you are doing a big service for these young patients. So that's what we did. Now let's say apexogenesis is something that you do in vital teeth, and let's say it didn't work out, or the patient is seeing you in the first place when the tooth is non-vital. If the tooth is non-vital, then obviously you can't do apexogenesis because there is no vital pulp. In that case, you have to look at other options. And the options that you have in front of you are revascularization, placing a bioceramic barrier at the apex, and then you can look at natural apexification itself. And then if nothing else works, then we look at surgery. All right, so let's look at each of these in detail. Let's start with revascularization. So what is revascularization? So let's say you have a case like this and the apex is wide open, but the tooth is non-vital. It's completely necrotic. So what are the options you have? It's the same here. You have a tooth here. You can see it's necrotic. It's not vital. There is no vital tissue here. So what are the options? You have an apexogenesis is impossible. you can try something known as revascularization. So what is revascularization? The theory is that even if the tooth is completely necrotic, at the apical part, we are going to find what we call stem cell in the apical papilla. Okay, and this stem cell is capable of regeneration. So the idea is if you can induce bleeding here from the apical area and allow blood to flow into the canal, then this blood clot will act like a scaffold into which the stem cells can invade and then start performing the way a pulp does. So the idea is these stem cells can invade this pulp space and then form a scaffold and then convert whatever tissue is there into sort of like a pulp-like tissue, which starts performing all the functions that a pulp is meant to do. So that's the theory, all right? And then in order to preserve this environment or kind of give some sort of a fluid-tight seal to preserve that scaffold with the stem cells there, the idea is to seal it with MTA and then a coronal restoration, so to preserve this environment. And the idea is if you do that, then new pulp tissue will develop and then continue to form root and also increase the thickness likely. So this is the goal, all right? In theory, it seems like a good idea because have a look at this case which somebody referred to me for retreatment. Looks like a tooth where somebody had treated this tooth endodontically, and you can see gutta percha in the canal, and they put a sort of a metal post and then build it up. And then this patient had a big abscess there, and that's why he came to the clinic. And now what I did was I was just expecting a routine retreatment case where I would just take out this, disassemble the tooth, remove this metal post, then remove all the gutta percha, then put some calcium hydroxide there, wait for the infection to subside, and then put a new obturating material there and build the tooth up and refer it back to the referral. This was the plan. But to my surprise, once I did the disassembly and I removed this metal post, then I removed the gutta percha that was there in the canal. Initially, I found a lot of drainage, but when I started irrigating, I found something fibrous there. And when I put in an H file and removed it, what I found was this huge chunk of pulp which just popped out. And I was really surprised because it's not something that you see every day. What this is actually a remnant of the pulpal tissue which was in the canal. So I can only guess at this point in time because the patient says that this was done when she was a child. So I presume that when this was done originally, some clinician back in the days filled the canal partially, but inadvertently left behind blood from the apex, which filled the canal. And that blood actually started getting invaded by stem cells, and a full-blown pulp tissue actually grew there. And it was kind of compressed here. And I don't know how exactly this size kind of managed to be there, but this is the only theory I can think of. It is a true story, all right? So that's the only explanation I can think of. So this kind of tells me that, yes, it is possible that you can have pulpal regeneration. So just to show you the steps, this is courtesy and another fellow endodontist, a colleague, Dr. Samir Jain, just to show you the steps involved in revascularization if you are doing intentional revascularization. So this is a case where you can see there's a lesion, the tooth is non-vital. So what Samir did is he did a passive disinfection with what we call triple antibiotic paste, that is ciprofloxacin, metronidazole, and minocycline, which a lot of people suggest. And then he put a little bit of calcium hydroxide for passive disinfection. And then he induced bleeding from the apical area. You can see here, that's the blood, and this is acting as a scaffold. He used a collagen matrix. A lot of people don't use a collagen matrix, but in this case he did, and then covered it with MTA and followed by a coronal restoration. And you can see this is a 3-month recall, and you can see the lesion starting to heal. And when he did a pulp vitality test, it actually responded. So this is how a classical revascularization is done. And sometimes it works. This is a case by Dr. Rajiv Patel, another friend who's an endodontist. And you can see this is a 7-year-old child. And the patient came to his clinic, and you can see here there's quite a big swelling labially and then filled with pus. So Rajiv went there, drained it up, and then what he did was he induced bleeding and then covered the surface with bioceramic putty, followed by a restoration on top. And then the patient came back, and you can see the sinus tract heal. And Rajiv actually followed this up at year 1 and 2. And you can see how the root formation is progressing here from an open apex, root formation, as well as some sort of a thickening here. Not a lot, but there's definitely a natural root formation here. Not a lot cervically, but definitely root formation apically. So this is a case where revascularization actually worked. So clinicians do get good results, and there are many examples like this on the internet or even on forums where somebody attempted revascularization and it works out well. But on the other hand, you can also get failures, okay? And this is from a very good clinician, a friend of mine, Marga Ree, a mentor rather than a friend, someone whom I look up to. So Marga did a lot of revascularization cases, and she compared her follow-ups. She's someone who does a lot of recalls of her cases. So Marga had a lot of failures as well. She had successes, but she had failures as well. So these are some of her failures where she did a revascularization on a 10-year-old girl. You can see necrotic, wide open apex. So Marga attempted revascularization, but at 2 years, you can see there is no change at all. It's the same. This is another case which she shared where there is an open apex. She attempted revascularization. At 1 year, you can see the apex is still very much open, whereas if you compare the 1-1, which is the adjacent central incisor next to it, you can see root formation is progressing normally in the unaffected teeth. So this is again a case where it didn't really work. So this is the problem with revascularization. It works sometime, and when it works, it's really nice, but there are a lot of cases where it doesn't work as well. So there is a bit of unpredictability. The second thing you can do is something called apexification, which is again inducing the body to do something natural to close this root apex. But unlike revascularization, you are not aiming at the natural root formation to progress. All we are looking at is some sort of a barrier to form. So with apexification, what we are looking for is, again, the situation is the same. So you have an open apex, but the pulp is necrosed, tooth is non-vital. So these are all situations. And in an apexification, what we are trying to do is we put calcium hydroxide, and this calcium hydroxide will sort of induce a mild irritation, which will promote undifferentiated mesenchymal cells in the apex. They kind of get activated, and then they differentiate into cementoblasts or osteoblasts, and then they start depositing hard tissue. And this newly calcified tissue, it could be either cementum, osteodentin, or bone. This bridges the apical opening. So you're looking at a natural barrier formation. Now, there are debates as to what exactly constitutes this barrier. Some say it's cementum-like material, some say it's bone-like material, and some say it's dentine-like material. Whatever it is, there is some barrier formation there. Okay, so this is what we are hoping to get in an apexification case. So I'll show you a case of mine which I attempted apexification. This was from almost 20 years ago when we weren't using MTA a lot and the patient couldn't afford it. So what we did here was the patient came with an abscess, so I drained it out and then filled it with calcium hydroxide. So you can see it's a bit thick here, and the reason why it looks a little more radiopaque is I've used something called as Metapex, which is like calcium hydroxide mixed with iodoform. The reason I prefer that in long-term cases like this, when you're inducing apexification, because in order to allow the time for apexification to happen, you have to leave calcium hydroxide for at least 6 months to a year. I usually leave it for a year. The regular calcium hydroxide dissolves in that period of time, but Metapex, for some reason, that's calcium hydroxide mixed with iodoform, tends to stay there for long periods. So this is what I prefer if we are attempting apexification in these sort of cases. Patient was recalled after 6 months, and I asked her to come back after another 6 months. That's a 1-year recall was what I was aiming for, but this patient turned up after 20 months. And then you can see here, there's a nice little barrier there in the radiograph. So what I did in her case was I removed all the calcium hydroxide inside. And when I looked inside, I could see a nice thick barrier, a uniform barrier. By the way, these pictures are taken through the microscope, and this is something that virtually anybody can do. If you get a microscope tomorrow, you can learn how to do this in less than a couple of weeks, or even lesser. So this is something that's very easy, an endo in an upper incisor, and to take good clinical pictures is something that anybody can do. So you can see, because we know that the barrier is uniform, I can just inject gutta-percha straight into that area because the barrier is really solid, and then just to backfill to whatever area I want. So this entire thing is backfill gutta-percha, and we're able to do that because of the barrier formation. Okay, so this is a classical epexification case. Now let's look at the third method available, which is bioceramic barriers. Now, the problem with epexification and revascularization is that both of them take time. So you have the third option here, which is creating this barrier ourselves by putting some sort of a material which hardens, like MTA, or when you say bioceramics, we're talking about MTA or bioceramic putty or even biodentine some people use. So all these materials are what we call bioceramics, and these materials are moldable, so they go towards the apex, and in the presence of moisture they can harden like a proper cement, and then we aim to create an artificial barrier there instead of gutta percha. So that's what we call bioceramic barrier. So this is a classic case of how we use MTA as a barrier at the apex. Instead of waiting for long periods for the body to form its own barrier, we create our own barrier with MTA. So this is a case where somebody had already done endo on both these central and lateral teeth. Unfortunately, not very well obturated. The patient had some issues and went back to the clinician, and then I think some oral surgeon did an episectomy here and a little bit of episectomy here as well. So we decided to retreat both these teeth. And when we removed the gutta percha, in the central incisor, I found that it was an open apex, and a size 80K file was going easily past the apex. So what I did was I removed the gutta percha, and when I look at the apex, you can see the apex is bleeding. So this is probably not a good environment to put MTA directly. So when I get a case like this, I usually like to put calcium hydroxide, wait for a week or two for the inflammation to subside, and then have a look at the apex after a couple of weeks to see whether it's inflamed or not, which is what I did. I recalled the patient after 2 weeks, and when I removed the calcium hydroxide, I can have a look at the apex. You can see there's tissue there, but it's not overflowing or inflamed. It's reasonably dry, so I know that my MTA will not get washed away. So this is, again, one of the advantages of using a microscope, because you have light which penetrates all the way to the apex, so you can visualize this. If you want to know how you can do this in your own clinic, then do have a look at my online course, specifically meant for the general dentist. I teach you how to get a microscope, what sort of microscope to buy, how to incorporate it in your own clinic, and then start doing cases like this where you can document all this yourself. If you want to know more, then do click on the link and I'll be happy to help you out. This is what we did in this case. Now we found that the environment was ideal to place MTA, so we put MTA there using something called a Dovgens carrier. You can use a MAP system or whatever carrier suits you. This has stoppers here, so you can deliver MTA into the apex. So that's what we did. You can see there's a bit of bolus of MTA there. So we visualize this MTA, whether or not it's sealing the apex, through the microscope, and then we verify it with a radiograph to see whether or not it's going exactly at the apex. Okay. And once you verify that, we can either backfill it a little more if you want, or you can even leave just the apical area and recall the patient after some time, ensure whether it's hard enough or not, whether it's set enough, and then put gutta percha on the remainder of the canal. But in this case, I filled a little more of the MTA, you can see here, and then we put a fiberglass post as well to add some strength. The lateral, we didn't have to put MTA because the apex was, I think, at 35 or 40, so I decided to just gutta percha in this canal, but this whole canal is MTA. So this is a classical MTA case or apical barrier where we put some sort of a bioceramic at the apex and create our own barrier rather than waiting for the body to create a barrier as we do in epexification cases. So this is the other method. Now, if you compare revascularization or epexification cases with, let's say, MTA or bioceramic barrier, the main differences, if you compare, are this. When you look at revascularization, it is time consuming. So you have to recall the patient, you have to observe the tooth, whether it's the roots forming or not, monitor these cases, and then intervene if nothing much is happening. So it takes time. The second problem is actually a huge problem because there is huge variability in outcome. And this is something that experienced clinicians share. Somebody who does a lot of recalls and track their own revascularization cases, they kind of see that some cases do well, but some don't do that well. So it's not something that you can standardize. When it turns out well, it's amazing, but there are a lot of cases which fail and nobody knows why they fail. Okay, so there is variability in outcome. And revascularization improves apical closure and sometimes cervical thickening as well. So what you're hoping for is some sort of a tissue inside which does everything that the pulp does. So you are kind of expecting that the tooth will thicken. The dentin deposition will happen the same way that it happens for a tooth where you have an intact pulp inside, like any other teeth. So that's the goal of revascularization, and that's why a lot of people are aiming for revascularization. However, one must be aware that the outcome is not predictable. Sometimes it works, sometimes it doesn't work. When you talk about MTA or bioceramic barrier, you don't have to wait. It's immediate. Most times we just go through one round of calcium hydroxide for the inflammation to subside, and in the second visit, we put a barrier. So it's very quick. Outcome is fairly predictable, but the barrier is only apical, so there is no cervical thickening. So you have to take measures to ensure that the cervical area doesn't fracture easily, and I will show you how we do that. When we talk about epexification, again, like revascularization, it takes time. However, the outcome is much more predictable than revascularization because you are looking at only forming some sort of a barrier at the apex. So in my experience, they are fairly predictable provided the coronal seal is good. Most of them will form apical barriers. So apexification is a fairly predictable procedure. The only disadvantage is that the barrier is only apical. So there is no cervical thickening, or you don't expect any dentine to form laterally. We are only expecting some sort of a barrier at the apex. Okay. So those are the differences. One of my mentors, or someone whom I look up to, is Marga Rie that you see in this picture. She practices in a place called Purmerend, which is near Amsterdam. And one of the good things about Marga is that apart from being an unbelievably skilled clinician, not just an endodontist, but an amazing restorative dentist as well. So what she has done is she did a lot of revascularization cases and then recall cases for a long period, 10, 15-year-old recalls. And there is this paper that I urge you to read if you get a chance, which Marga has written with Rishwartz, where they actually looked at long-term recalls of different procedures. And Marga's conclusion is that MTA apical barrier with adhesive restorations heal, and they remained in function for long periods, almost 15 years. So she advocates this as a very predictable way to handle these sort of cases rather than looking at revascularization, which is not as predictable. So that's her verdict, and I would listen to someone like that who is a pretty experienced clinician, skilled clinician, and has her own recalls for a very long period of 15 years or so. So this is the danger. If you get these sort of fractures cervically, then it's a problem. So one has to take some measures. And what Marga advocates is to put a thick fiberglass post, and that's something that I've been following for the last 15 years or so. Whenever we have a tooth, you can see that's MTA there, and after checking whether the MTA is hardened or not, we put a fiber post, and often there's so much of widening there. These teeth are so immature, so there's such a large space coronally that even the largest fiberglass post is loose. So what we usually do in such cases is we invert the post, like what you see here. So the thinner portion is on top and the thicker portion goes in there. Because remember, the goal is not to put restorative material. The goal is just to strengthen that coronal portion so that it doesn't snap that easily. Okay? So you find a lot of our cases, when we treat open apex cases or immature teeth, you will find these fiber posts throughout. Okay, so you can see 2 fiber posts here. You can see again here, this was a open apex case. And from here to here is actually a fiberglass post. So I kind of follow that as well. And the goal of doing that is to prevent this cervical snapping here. Okay? And there are a lot of studies to back this up. In case if you need, then just send me a message and I'll be happy to share those papers with you about how a fiberglass can strengthen these teeth coronally. Now let's look at some more clinical cases. You can see here, this is a case where somebody had treated this tooth and then patient came back with a very large lesion. Now, how do you make a decision as to how to treat this? The problem with this sort of case is, if you look at an immediate apical barrier, it's not that easy because let's say you put an MTA barrier and then the patient continues to have some symptoms, then you are left with only the surgical option, right? So for such cases, I like to do long-term epexification. Why? Because I want to put calcium hydroxide and monitor this lesion, kind of shrink this lesion to some extent. And if you look at this tooth, this is what I did. This tooth was not a problem, so I clean shaped and obturated that. Whereas this tooth here, I removed the gutta percha. I kept the crown temporarily, and I removed the gutta percha. And while removing the gutta percha, a part of it kind of slipped past the apex, but I didn't bother. I left it like that and then put calcium hydroxide. This patient was supposed to come back in a month's time, but she came back after 2 years. Like a lot of these patients, that is the problem. Once the pain disappears and we tell them to come back in a month or two, or after 3 or 4 months, they usually disappear and they suddenly remember only after 2 years or 1 year, 1.5, 2 years, they suddenly remember to come back. So the goal here was, I was hoping for this lesion to subside and then decide whether to put MTA there or do something else. But this patient turned up after 2 years, and you can see the calcium hydroxide is very much there because, like I said, I use something called Metapex, which contains iodoform. So it doesn't disappear that easily. So what you're seeing there in the canal is calcium hydroxide mixed with iodoform. And you look at the temporary, it's still intact. So the patient showed up 2 years later, and then when you look at this case, what we are seeing is that the entire lesion is healed. So if you compare how it was in 2011 with how it is in 2013, you can see the whole lesion is healed completely. And there's some evidence of barrier formation there as well. So what I did was, you can see the temporary is intact. So we removed that, and then you can see the Metapex inside. And then when you zoom in there and remove the calcium hydroxide, you can see a nice uniform apical barrier. You zoom in there, you can see how uniform the barrier is. And this is something which the body has formed. This is a classical epexification. So it's the apical tissue, the mesenchymal cells, which lay down this sort of tissue, which could be, I don't know, cementum or dentine or bone-like material or whatever it is. But that barrier is something which is what you want to see when you recall these cases if you're aiming for epexification. So once you know that the barrier is solid, and that's the view that you get through a microscope of that apical barrier. And I verified that if you put a cone, it was meeting resistance there. So we have a nice little barrier there, and you can condense whatever you want against this. And in this case, I injected gutta-percha from a backfill device straight into the apical area, and it can withstand the condensation pressure. And then I put a fiberglass post for additional strength. So this is how it looked post-op. And then if you compare the pre-op and the 2-year recall post-op, it looks pretty good. And now we tell the patient to change the crown. So this is a good case to demonstrate how to handle if you have a large lesion, because you don't want to go into surgery in large lesions because it's very invasive. So this case illustrates a combination of putting calcium hydroxide, waiting for the lesion to heal. And after it kind of heals halfway, you can either put MTA, or if you leave it for a longer period and you get epexification, which means the barrier forms naturally, then you don't have to put MTA, you can use that barrier itself. Okay, so this is a good example. This is again a case where there was a very large lesion from canine to canine. So this patient was originally referred to do root canals in all 6 teeth by the oral surgeon. So the plan was to do endo from canine to canine, and then the surgeon was planning to do this in the operation theater, kind of curate the whole lesion, which was a quite invasive procedure. But when I checked the vitality here of these 2 teeth, I found that only these 2 teeth were non-vital. The other teeth were vital. So what I decided to do was long-term calcium hydroxide therapy of this teeth and see whether or not we can get some shrinkage. So you can see quite a big lesion here. And if you look at the apices, it's quite open, open apexes with large lesions in both these central incisors. So I put calcium hydroxide, and then we decided to just treat these 2 teeth and leave the rest as it is because they were all vital teeth. So the goal was to somehow shrink this lesion, and even if they are planning to do surgery, it's much easier to do surgery when the lesion shrinks rather than at this stage where it becomes a really invasive procedure on a very young girl of, I think, 11 years or something like that. She was 10 or 11 years old. And so this is what we did. We recalled this patient September 12. A year later, you can see the lesions starting to improve. And then 2 years later, you can see the lesions completely healed. And then in March 2015, you can see the lesions completely healed with just Metapex in the canal. So this is a really good result. And once we saw some evidence of barrier formation, so there is a difference between these 2 teeth. Here we can see the barrier doesn't seem to be that uniform here, but here you can see the barrier is very uniform somewhere here, okay, or somewhere here rather. So what I did was I removed this temporary filling and then went in there, removed the calcium hydroxide, and I could feel resistance at this depth here. And when I looked into that area through the surgical microscope, I can see a barrier here, but the barrier is not uniform. You can see bleeding here. So in this case, I wouldn't want to inject gutta percha directly into this area because I can see there is a barrier, but it's not uniform. So in this case, I would put MTA here. And that's the advantage of visualizing these areas through the surgical microscope. Like I said many times, if you feel that this is something that you cannot do, think again. Do have a look at the online course where we teach dentists, general dentists, how to do this. And this is something I've been doing for the last 10 years. And we have so many students who are general dentists who come to us. We literally handhold them and teach them how to use a surgical microscope into their general dentistry practice. And what you see here in front of you is something that almost all of them do in their general dentistry practice. So do have a look at the online course, and hopefully many of you take that leap into buying a surgical microscope in your general dentistry practice. Okay, so what we did was we put MTA into that tooth there. So you can see here, I put a blob of MTA and then again visualize it through the surgical microscope. This might look like it's short, but the fact is this whole area is actually calcified, although you can't see it on the X-ray. Even if I put pressure on this MTA, I can't push it anymore because there is a barrier formation here. Okay. So that's the MTA there. So what I did in this case was I wanted to make sure that this barrier is hardened because there was a bit of bleeding there, right? So in such cases, I don't like to immediately close it up. I like to put some cotton pellet there, close it with a temporary filling, recall the patient after a few days, check if this apical MTA is hardened or not, and then put a fiberglass post here for additional strength, okay? And then what I did was I went into the next tooth to remove the temporary and inspect the apical barrier. So when I removed this temporary here, the barrier was somewhere here. So when you put a gutta percha, you encounter resistance here. And when you look at the apical barrier, here the barrier is quite uniform. It's not bleeding or anything. So in this case, I injected gutta percha directly into that area. The barrier is quite uniform. So I didn't have to put MTA, so I injected gutta percha. And then that's the gutta percha there. And then we put a fiberglass post in both these teeth. The MTA hardened, I put a fiberglass post in that as well. So you can see that's the post top. So you have MTA here, fiberglass post and core. This is gutta percha and fiberglass post and core. So this is how we started and that's how we ended. And if you look at the cone beam CD, you can see this is the first one. You can see here, although it appears short, this whole area is kind of calcified, but there is a periodontal ligament sort of, I don't know what that is. But yeah, I would say this is a pretty good result considering where we started. And the one that's longer, although it looks overextended in the radiograph, you can see even that there is some sort of a ligament which is formed around this barrier, the natural barrier laid down by the body, which I don't know what material. It could be just bone or dentine or cementum, I don't know what, but there is a barrier there. So this is again an example of apexification, natural barrier which is formed by the body itself. This is how we started and that's how we ended. This is how we started and that's how we ended. Okay. Now, if none of these options work, then you have surgery, or even if you haven't tried any of these, but the patient doesn't have that much of time. Let's say in our practice, for example, we have patients who fly in from overseas and then they're there only for 2 or 3 weeks. And obviously that's not enough time to experiment with things like apexification or revascularization. In these cases, we do immediate surgery, or sometimes we attempt non-surgical methods, and if it doesn't work, then we move on to surgery. So these are usually the indications for surgery. So this was a surgical case where the patient came from out of town, had very limited time. So what we did in this case was we removed these crowns, and you can see what looks like calcification, and this looks like a perforation. So the goal was to redo this tooth, and both of these needed to be treated in 1 or 2 visits rather than do long-term recalls because the patient didn't have that much time. So we removed both these crowns, and you can see the lateral incisor. When we removed the restoration on top, the temporary filling on top, we found a large perforation. We located the missed canal there, so that was the canal, and then we sealed the perforation with MTA, and then that's the gutta percha in the actual canal, and that's the MTA, repaired the perforation with MTA, and then closed this with a permanent restoration. So this is the process, and you can see here, that's the restoration of that tooth there, that's the repair of the perforation. And then we went on to this tooth. We removed all the gutta percha there. You can see we removed it up, and that's the tooth. And you can see inflamed tissue. So it's not ideal, but because we were doing immediate surgery the very next day, what we did was we put MTA forcefully into that area, extruding it a little bit apically, knowing fully well that we are going to do immediate surgery. So in this case, we extruded MTA and then did a coronal restoration, a fiberglass post there, and we immediately raised the flap, curated the lesion, and you can see the MTA there, and then flattened the tooth as well. So that's the MTA. So this is the immediate post-op. So you can see here, that's immediately after retreating and filling it with MTA, and this is after curating the excess MTA out and smoothing the root there. And this is a 2-year recall. You can see it's healed completely. So this is the pre-op, and you can see the post-op, which I think is a pretty good result. So surgery is pretty good. It does give pretty good results, and it's predictable, but we usually reserve that for when the lesion is small and compact rather than a huge lesion. When the lesion is huge, we want to do something else with open apex cases and bring down this lesion. And typically that's long-term calcium hydroxide, or sometimes even methods like decompression, which we will talk about in another video in the future. So that's how we manage an open apex case in our clinic. If you'd like a free PDF which helps you in making a decision, sort of like a flow chart, which helps you diagnose a case which has an open apex and gives you the exact treatment option that you need to follow depending on your clinical scenario, then do click on the link that comes up below, and I'll send you a free PDF which you can keep in your clinic and which will help you make a decision as to what sort of treatment to follow in that particular case that you might get in future in your private practice. If you enjoyed information like that and you'd like to see more videos, then do check out some of my other videos that you see here. And don't forget to click subscribe so that you get notified when I upload a new video next week. See you next week with another video.